welcome to another episode of Decoding DX. Today we have a really cool case of acute vision loss, and our discussants are Rachel Jenkins, joining us back again, our fellow MS3, and then Dr. Ralph Modi, who's joining us for the first time. So if you guys want to quickly introduce yourself, say where you're at in training, and then something about you that doesn't involve medicine. And Ralph, we'll start with you.
Sure. So I'm Ralph Modi. I'm a third-year internal medicine resident. Well, this is sort of a medicine, but I actually discovered when I was a med student that I have an aneurysm, having done volunteered as a ultrasound model. So that's something about me.
I hope it's a benign one that they don't think is going
to
too bad. Good. That's always fun when the volunteer ultrasound actually finds something.
I know, right?
And Rachel, tell us something, see if we can come up with something different this time.
My name is Rachel Jenkins. I am a third year at the University of Kansas, nearly done with third year. 2 more rotations left. And let's see, all I can think about is I really like buffalo chicken dip, and I'm planning on making some this weekend for the football game. So that's what's getting me through the rest of this week.
Perfect. I love it. Alrighty, with that, let us go ahead and jump in. And our lovely Kelsey is going to be scribing tonight. And our chief complaint is right eye complete vision loss. Patient presented to the emergency department at KU. So quickly, with just that chief complaint, Rachel, real quick, do you have any sort of like an approach when you hear vision loss? How do you think through it? What comes to mind just off the bat?
I would definitely want to be, quick to think about any sort of thing that could be permanent vision loss, so want to think of more like any sort of stroke or hemorrhage or something that's causing it. But definitely I'm going to have to find out more from this patient about when it started happening, if it was totally sudden or if there was any gradual, and then definitely some other past medical history that could, kind of help to stratify out risk factors for stroke or some other type of etiologies for right eye vision loss. The eye is definitely not something I'm super familiar with. So it would probably take some, looking on the computer at some of my top things that I need to be ruling in and out. But overall, I want to make sure that if we can get their vision back, that we identify it so we can do that quickly.
For sure. Ralph, what about you? Do you have any sort of framework or way that you would approach vision loss?
Yeah, I quickly categorize it based on, number one, how old the patient is. I know you guys have probably talked about in your third and fourth year about pretest probability. Ischemia is probably far, the most common etiology in older patients. So old is defined a little bit more vaguely. Old could be greater than 50 or greater than 65. But if it's a young patient, I'll want to get that idea of what could be the most common cause initially. And then I also separate it into trauma or not trauma. That's my initial approach.
I think that's really big. I think especially in the emergency room, we always have to think about what could really hurt the patient right now. So on that note, what are kind of some can't miss diagnoses that if you were in the emergency room, you would immediately want to consider or rule out?
One thing that you always have to, whenever you're talking about either transient vision loss, whether that's monocular, binocular, sometimes the patient can't tell, so you have to assume it's either or acute sustained vision loss, is giant cell arteritis. It's also called temporal arteritis, but that represents an entity that you have to rule out in almost all cases because it is a cause that you can reverse right off the bat, i.e. steroids. And then, of course, another one is if you're examining the patient in the emergency department or the ED bay and, they're suffering trauma to the head or they hit the head with a baseball bat and they have a globus injury or something like that, that also represents an intervention that can save their vision if done fast.
Yeah, absolutely. Just to kind of add extra schema to the discussion, I think, Rachel, I agree with you that the eye is not something that I am most familiar with nor comfortable with. So when that tends to happen, I tend to default to just an anatomical way of thinking about it. So like with the eye, I think about first, it could be the eye itself. So there's the cornea, the retina, the fluid that's within the eye, and then there's the optic nerve itself, and then there's back in the brain. And so just thinking through the things kind of hits a lot of the things you guys talked about. Like it could be an inflammation, like a vasculitis. It could be some sort of a stroke or some sort of issue with the optic nerve itself. So Rachel, you mentioned some questions that you'd want to ask her. What types of information would you be looking for, particularly in the HPI? And then I'll give you some of that info.
I mean, I would ask, what happened, kind of tell me your story about when you noticed your vision loss. So that would kind of get us if there was a traumatic event or if it came on suddenly. How long it's been going on, any other associated symptoms, such as a headache or fevers, eye itchiness, eye pain, any past medical history that they might have. Any medications that they could be on. I mean, yeah, for kind of specifically for the symptoms going through your old cart. So yeah, onset, location, CI, but how long it's been going on, all that sort of thing.
Yeah, for sure. I think one of the, really helpful ways to kind of get some branch points with vision loss is, like you've already said, like, is it acute? Did it happen like all of a sudden? Or did it kind of progressively come on? Because that can help you differentiate between like, is this an embolus that went to the orbital artery? Or, is this some sort of like a slow ischemic process or something like that? And then is it painful? That's a big branch point as well with different eye pathologies. And then just kind of probing, this is more like in the ophthalmology world, but kind of probing into like, can they see motion? Is there color issues? That'll help to key you into kind of where it's located at. So on that note, some more info from the HPI. So the patient reported complete vision loss in her right eye that started 3 to 4 days ago while she was watching TV. She can't really say if it was like sudden or gradual, but she does say that it was normal 3 weeks ago when she saw her eye doctor. So she can't say a specific moment that it happened, but it's been within the last 3 weeks. Along with this vision loss, she's kind of had some more fatigue. She had a little bit of a nosebleed a few times, and she said that she had some cough that kind of brought up maybe some red spots, but she wasn't sure, and she did have some headaches. We asked specifically more about the nosebleeds, and she said it was out of both nostrils, and it had some tenderness around her face, and kind of just, she said that her nose was runny, and so it like started getting kind of raw, like it happens sometimes when your nose is runny. But she thought that this felt like prior episodes of sinusitis that she had. We asked more about that, bringing up blood when she coughs, and she wasn't really able to quantify the amount besides saying that it just kind of got on some tissues, but this had never really happened to her in the past. And then she also said that she had those intermittent headaches, but she couldn't really describe them. She didn't say that they were too debilitating, but she, said that they just kind of come on and off, and she can't really say what triggers them or anything like that. She has no past medical history. She does smoke 2 packs a day, and she's done that for about 50 years, so 100 pack years. I'm trying to remember. I don't think I said her age earlier, so that's important. She is a 67-year-old female. So she's been smoking for most of her life, and she does drink 1 to 3 glasses of wine per day with dinner. Not on any medications, and review systems was pretty much pan negative besides for everything in the HPI. So no fevers or chills, no nausea or vomiting, diarrhea, no jaw pain, no shortness of breath or chest pain, no changes in urine habits, no weakness or numbness. We asking a little bit more about kind of the eye symptoms. She didn't have any photophobia or phonophobia, no dizziness, anything like that. And then I will go ahead and jump into the exam to give you guys a bit more information. In general, the long and short is that most of the exam was normal. And then jumping to the neuro exam. Her cranial nerves were all intact. Her extraocular movements were intact. And her right eye perception of light and hand movement was intact, but decreased acuity. So basically, she couldn't distinguish between fingers, but she could see that the hand was moving in front of her face. all of her visual fields were intact, so there wasn't a particular side that was worse than the other. And then other than that, her neuro exam was normal. So normal muscle tone, normal strength, normal sensation, and her coordination and gait were pretty normal. So that was a ton of information. Rachel, looking at that, what pieces of that information kind of key you as, red flags or really important, maybe pivot points in the case? And what is that making you think about as far as your differential right now?
I have a question. So were these nosebleeds within these past 3 to 4 days as well, or what was the time frame for those nosebleeds?
Yeah, so she's not the best historian, but she said that it's been, about the last few days, maybe a few weeks, so along the same time as the other symptoms that she's reporting.
That's interesting. Nosebleeds and then also the headaches with this vision loss as well. I feel like the first thing that I'm most concerned about, and that at least right now would be one of the more severe things, would be some sort of increased intracranial pressure type process, wanting to rule that out. Also with it, she's still having some perception of movement. It's just more decreased acuity. I'm not as concerned as some sort of stroke because it's not totally cutting off that, the nerves sending back. With that, I would just expect total, not seeing anything at all from an eye or a certain visual field. So I would think that it's something within the eye more causing the blurred vision.
Yeah, for sure. Ralph, I'll put that same question to you at this point. What sticks out to you and what are you concerned about right now as far as a differential?
And so her nosebleeds were truly blood. It wasn't like clear fluid coming out. Okay. And you said that she's not having any eye pain, or she is having eye pain?
Not specific to her eyes. She's having kind of headaches on and off, but not particular eye pain itself.
Okay. I think that, and then did we do an ophthalmologic exam? Sorry to ask questions, because the part of the exam, I didn't see that anyone looked in the eye.
Right. So at this point, no.
Hold on. Okay. All right.
We are going to consult ophtho, but at this point in the ER, an ophtho exam was not done.
Okay, gotcha. So I think what helps me in my mind is that increased intraocular pressure is typically associated with eye pain, and so the absence of that narrows our differential. What worries me is that she described a negative phenomenon as her vision just got worse. If someone described a positive phenomenon, on the other hand, like scintillations, scotomas, photopsias, and you could think seizure or migraine. But if it just got darker and now she has only to hand motion, then I think retinal ischemia right off the bat. And the question becomes, why are they having retinal ischemia? That's sort of a garbage term. It could be due to optic nerve disease. It could be due to intracranial disease. The headaches may be a distractor, but the nosebleeds timing at the same time is worrisome. It could be that she has a coagulopathy.
For sure. So given all those thoughts, what would be first on your list of orders that you want to get to start this workup?
Oh, an eye exam, either like a panoptic or a direct exam. And
then while kind of some of that is going on, while labs are being sent back, any empiric therapy that you would start?
So I wouldn't necessarily start any eye drops right now. I think that if ophthalmology came by or in the emergency department, they had a tonometer and they were able to show to me that there was truly increased intraocular pressure, then you can prescribe a multitude of eye drops. But right now there's no medication that I would give necessarily. In addition to basic lab work, I would want that ophthalmologic exam to narrow down my differential.
Awesome. Okay, so I'm going to give you guys a bit more information. So initial labs, initial imaging, and then I don't have the exact report of the ophtho exam. I didn't get this patient until she was admitted, so I don't have everything from the ER records, but I do know that they did take her ocular pressure, and her ocular pressure was normal, and they didn't see any signs of acute ischemia on retinal exam. So her initial labs and imaging, she did have a white blood cell count of 16.4. a hemoglobin of 12.6, and a platelet count of 700. And then her sodium was 132, Potassium was 3.5. Chloride was 96. Bicarb was 25. BUN of 14. Creatinine of 0.89. And a glucose of 189. And then her AST was 84. ALT was 63. Total bilirubin was normal at 0.4. Her alk phos was 272. And albumin was 3.1 with a total protein of 7.1. And then some inflammatory markers. Her sed rate was 115. And her CRP was 23.73. And then a UA was also ordered that had a specific gravity of 1.008 with 2+ blood, and otherwise all within normal limits on the UA. And then an initial chest x-ray was done that showed some patchy nodular opacities within the right mid-lung and apex. It was read as indeterminate, but could reflect all sorts of things, including nodules, infection, or small hemorrhage, and the likes. So, given that information, Rachel, starting with you, what do you think the disposition for this patient is? And also just tell me what changes to your differential or what's going through your head with this extra information. What stands out to you?
Yes, so there's definitely some sort of process going on in this patient that we need to figure out. So I would definitely admit her for further workup. We can't send her home at this point. And on changes to differentials with that increased white blood cell count, the platelets, the ESR and CRP, those are all concerning for some sort of acute inflammatory response to something. So anything that falls into that category, which is a lot, would jump up to the top of my differential. The chest x-ray, until we understand more, I'm sure once we know what it is, we'll be like, oh, that's why the chest x-ray looks that way. But right now that doesn't, there's a lot that could be, on the readout. The small hemorrhage stood out to me just because I was kind of thinking along those lines when she was also having these concurrent nosebleeds.
Totally. Ralph, what about you? What are thoughts on, I think we can all agree this patient's going to be admitted. What consults would you consider on admission, or would you want to do any more workup before she heads upstairs or before consults comes here?
Sure thing. So a couple of things I would order. I would, number one, now I'm only a third-year resident, so when it comes to advanced imaging of the lungs, I usually confirm with my attending. But one thing you could entertain is getting advanced imaging of those whatever nodules you're speaking to in the lungs. Usually a CT scan will be your first go-to. Second off, your AST, ALT elevations, as well as alk phos being elevated, is concerning. You can go down the pathway of, is this the liver, which it probably is, and get a GGT or a 5-nucleotidase or fractionate your alk phos. But so you have the lungs, you have the liver, and then you also have hematuria. So urine microscopy to evaluate what exactly the hematuria is. If you have dysmorphic red blood cells, regular red blood cells, is it overcalling hematuria and it's something else like a pigment? I would evaluate the liver. I would evaluate you can do a ultrasound, and then also the labs I was talking about. There's also evidence of like a blood cell dyscrasia. So thrombocytosis, anemia, leukocytosis. Did we have a differential on those? Were they blasts? Were they atypical white cells?
Right. I don't have it in front of me. Just thinking back to this, I think it was primarily lymphocyte predominant with also an elevation in the neutrophils, but notably no atypicals, but definitely present with the lymphocytosis.
Gotcha. Okay, thank you. And so I would get a blood smear to see if there's any atypical blood cells. And then the ESR CRP gives sort of a bird's eye view in my mind, saying that there's an inflammatory process going on, and it may tie together. It may very well be a vasculitis. It may well tie together the nodules in the lungs, the inflammation in the liver, the hematuria, which could be glomerular disease in nature. She could also have a blood cell cancer, and then there is an accumulation, and it's possible that I'll give you a story, for instance. Imagine she had a blood cell cancer that's affecting all of those organs, and then she's hypercoagulable and she clots off either her retinal artery, retinal vein, ophthalmic artery, and that's what's causing this right here. The headache, so if we go down the rabbit hole of we're now dealing with a cancer patient, although we're very undifferentiated at this point in time. The headache always makes me worried about intracranial disease involvement. So to revisit that symptom, which I first sort of discounted.
Yeah, I think those are all really great points. Really great thoughts about like further workup and not letting any of these, at this point, any of these signals could be pivot points. We really, like you said, it's pretty undifferentiated at this point. So not letting go of any of those, and it's important to prioritize, but never completely eliminate something from your head. That's just not important. So great point with that. So we did get a CT chest with contrast while she was in the emergency department, and that showed multifocal areas of consolidation within the right lung. And they read it as findings most compatible with multifocal pneumonia rather than any sort of neoplasm. But then they saw multiple additional small nodules and ground glass opacities scattered among both lungs. And then they listed quite a differential of what that could be, including infection, metastatic stuff, or various inflammatory patterns. So given that read on the CT, Rachel, what do you think would be, high yield consults to think of as far as the workup that might need to happen? And then after that, any empiric treatments that you think, and then Ralph, I'll pivot the same question to you after Rachel.
I feel like getting the peripheral smear is something that we could do, and then at that point, depending on what it read, we could potentially consult hematology if there was something concerning at that point. This is a lot going on in the lung. I don't know if I think I would personally consult pulmonology as a third-year medical student, because I wouldn't be able to handle this personally, but I don't know what a trained internal medicine doctor would think about that. But it is a lot going on there.
I agree. I think that whenever I consult a service, I usually have a question for them, because that's inevitably going to be the annoying thing. You have to talk on the phone with them. My question for them would be, what do these nodules and GGOs, ground glass opacities, represent? And does the patient need a biopsy? What we call a EBUS, or an endobronchial ultrasound guided biopsy. I don't think I would consult hematology just yet, nor do I think that I would consult, now if we think about the organs that we're dealing with and the respective consultants, I don't think I would consult hematology, nephrology, hepatology yet. I think I still need more data. Like Rachel was saying, I'm waiting on the smear, I'm waiting on the urine microscopy, and I'm waiting on the liver evaluation.
And then any empiric treatments. Let's say she's being admitted at 7 at night, and there's no way a consultant's going to see her tonight. So anything that you do for her overnight.
So you mentioned that her vitals were fine. So, the reason I'm asking that is if you see a leukocytosis, one thing, other than inflammation, I worry about infection. And so with the vital signs being fine, that means that she's not hypothermic and she is not fevering. She's not tachycardic and she's not tachypnic, i.e. the SIRS criteria. And so if she has just the leukocytosis, then it's not enough for me to say, let's start antibiotics. I don't even know what I'm starting antibiotics for. If she is stable, then I still don't think any therapy is merited. We should figure out what we're dealing with before we start with treatment.
I like that approach. I listened to a podcast recently that talked about the fallacy of ready, fire, aim, and that we can fall into the trap of triggering some pretty intense treatment sometimes before a full workup is done. And while sometimes that's merited for empiric treatments, sometimes we get a little ahead of ourselves. So as long as the patient's stable, like you said, if you don't know what you're treating, maybe just consider risk-benefit analysis of some of those empiric treatments.
Absolutely.
So consults that were ordered when she was admitted, ophthalmology was consulted, largely I think to do some of that more in-depth opto exam that few other people are comfortable doing. Pulmonology was also consulted, and they included on their differential a lot of what you guys had said: infection, malignancy, vasculitis, atypical fungal etiologies. They recommended doing a bronch with BAL, and they were planning to do that the next morning. And then the team that was admitting her was also concerned about like the vasculitis picture. So they went ahead and consulted rheumatology. I know Ralph had mentioned the giant cell arteritis picture earlier, and then with the hemoptysis, they were also just kind of concerned about vasculitis. So they went ahead and got rheumatology on board. Some more information for you guys, some normal results that came back. So some of the further workup was done. And just to simplify it, I'm just going to say that they're all normal, and here's the list. So a peripheral blood smear was normal, besides some increased platelets that we saw with her thrombocytosis. Procalcitonin was normal. A hepatitis panel eventually came back as normal. Her COVID test was normal. This was, I think, in September, so COVID was negative. Her strep pneumo and Legionella urine antigens were also normal. So with that being said, Optho and Pulm talked with rheumatology together, and they decided to start her on high-dose IV solumedrol for empiric treatment of possible giant cell arteritis. That was kind of their top concern, and wanting to, I know, Rachel, you said earlier you want to avoid vision loss if at all possible. And so their suspicion for infection was low enough that they were comfortable recommending to start steroids, while we then scheduled her for a temporal artery biopsy. That being said, while I think one of the things that we can sometimes miss when a patient like this is admitted, there's kind of this fun, exciting workup. It's academically interesting, and there's a lot that this could turn up being. But Rachel, when you mentioned earlier that, we want to make sure that we preserve her vision all that we can, that really kind of made me think about, like, what are the biggest risks that we may overlook when this patient is admitted? So what are kind of the iatrogenic risks that we could see this patient develop just from, the weight of getting a diagnosis? What would we want to be monitoring for to make sure that things don't progress? So you mentioned like progression of vision loss. Is there anything else with the data that we've had so far with her that you would maybe be worried about, that you would, let's say you got there in the morning to pre-round and you were like, I want to check on this just to make sure she's okay in the morning?
I mean, I think kind of what we talked about currently, she's stable vitals wise, and everything's within normal limits. But with some of these inflammatory markers, something's going on. So I'd want to definitely check her vital signs right when I got there to make sure, and throughout the night, to make sure there's no crazy temperature spike or drop in blood pressure or anything like that. And then probably including the vision, but also just neurological checks in general for any other focal signs that could come up. Yeah, really, I'd probably just want to keep a close eye, and probably the best person to ask would be the patient herself, checking in frequently and just saying anything else, any pain anywhere, those sorts of things would be the best thing to do.
I love that. If you ask the patient, they'll probably tell you what's wrong with them. That's great. Ralph, what about you? What would be some of the biggest risks that you would think about for this patient that you'd be watching for?
Yeah, so serial exams for increasing ocular pain, increasing headache, and then worsening of that of the vision. So the reason why each one, so increasing ocular pain, I'm thinking that maybe they had normal intraocular pressure and now they're having worsening intraocular pressure, i.e. getting higher. And so that therapy is different than giant cell arteritis therapy. Worsening headache makes me think that something intracranial is going on and it's worsening, i.e. mass, bleed, etc. And then worsening vision loss rapidly makes me think of retinal detachment, something that we can intervene upon and re-engage ophthalmology.
Yeah, those are awesome. Those are all really great points. I think the value of serial exams can't be emphasized enough. I think, especially with abdominal exams, neuro exams, eye exams, stuff like that, those can change rapidly and can really give you a good pivot point on how your patient's disease is developing. Some other things that were just kind of on our list as this patient was admitted was just really not knowing what was going on in her lungs. That was kind of a battle this entire admission, was that we just couldn't, it wasn't clear what was going on in those lungs. And one thing to keep in mind is that, patients with some of these ground glass opacities and, you're not sure if it's infectious or DAH or what's going on, trying to get them in for a bronch as soon as possible. That's not something that we control as the primary team, but because they can pretty quickly decompensate and be not stable enough for a bronch, which can be really important for diagnosis. So that was something that my attending made sure was on our radar, just wanting to make sure that we keep tabs on her in case she decompensates with her pulmonary status. And the other thing was just watching the renal involvement. Again, there was just a concern for vasculitis. And so knowing that there was some potential bleeding in the lungs, we wanted to make sure that we noticed immediately if there was any sort of a pulmonary renal syndrome going on, which would key us into some of the, bigger vasculitis pictures. So that being said, one thing I wanted to touch on real quick was, so she's being started on some crazy high doses of steroids here. So expected side effects, what would you tell the patient to expect as far as what she might feel when we start these? And then anything that you would expect on her labs or vitals or anything else like that that you would expect to be normal with the steroids that you wouldn't per se want, freak out about or try and intervene on. Rachel, start with you. What comes to your mind, and then we'll move to Rob.
From the patient perspective, right away, she's probably just could start feeling some increased agitation. That could be the steroids, or that could just be being in the hospital, not knowing what's wrong with you. Difficulty sleeping, weird dreams. And then on labs perspective, I mean, seeing a spike in her glucose is going to be expected. And also in her white count potentially too. She already has a high white count, so it might be a little bit difficult to sift through that. But the steroids are also going to cause an increase in that. So if it just increased a little bit, I probably wouldn't be too like, oh no, there's an infection or something, just because those steroids are going to come in and knock those neutrophils out into the bloodstream.
I think those are all great. Did you mention blood glucose as well, Rachel?
Yeah.
Oh, well, that's the huge one, inpatient. Runaway blood sugars. You mentioned the neuropsychiatric effects. Typically, if I remember correctly, the dose for giant cell arteritis is like 1,000 of methylprednisolone a day, either IV. And so that is a lot of steroid. And you probably will not see any electrolyte derangements, but methylprednisolone has a little bit of mineralocorticoid, and so just for the sake of academia, mineralocorticoid excess is hypernatremia and hypokalemia.
For sure. So mentioning the runaway blood sugars, what would be your threshold for starting insulin, and what type of a regimen would you typically start for steroid-induced hyperglycemia?
Yeah, the American Diabetes Association has no guidelines on steroids-induced hypoglycemia, nor does the American Society for Endocrinology. And so the target for blood glucose control in-house is 140 to 180. And so anything more than 180 persistently is when I'll start considering insulin. And what type of insulin to use is depending on the type of steroid. So if this is prednisone versus dexamethasone, i.e. how long the steroid remains in their system, that drives me to choose what type of insulin. This is most commonly seen in our hematology patients who come in and get high dose steroids as a result of as an adjunct to their chemotherapy. For instance, if someone is on, the most common one to use is insulin NPH, neutral protamine hagedorn. So that one can be dosed twice a day or 3 times a day, most commonly twice a day, as it lasts around 12 hours and allows you to titrate the next dose at the 12-hour mark. It's not wrong, and it has been done in the literature, if you are on a long-acting steroid, i.e. dexamethasone, to do insulin glargine, which is the 24-hour one, or insulin detamir, which is the 20-hour one. So those are all have all been used. The most common one, and the one that's most comfortable, or hospitalists and hematologists are most comfortable with, is probably insulin NPH. So how would I approach this? Coming in the morning, I would see that their blood glucose is high. Usually, so the best thing to do is to see what their morning chemistry shows, because phlebotomy will come around 4 a.m., 4:30, and get a BMP or a CMP if you've ordered it. And this represents the fasting glucose. This represents how you should tailor your long-acting insulin. And then hopefully, if you had thought of steroid-induced hyperglycemia beforehand, you either got with meals and at 10 p.m. or 5 times daily finger stick checks. So you could have 24 hours worth of data to see what their mealtime and their steroid excursions are like. And so that's how I would modify my long-acting insulin. And then that's how I would modify my either mealtime or add on NPH in the daytime when they're getting their steroid.
That was gold. Thank you so much for all that input. That was really helpful. All right, so I will say one more bit of information. The temporal artery biopsy was finally able to be done, and it was completely negative for GCA. The team was pretty confident that this was a kind of a slam dunk case for GCA, and was kind of surprised when that came back negative. And they did do multiple sites on the temporal artery. That's a classic boards question is making sure that you do multiple sites because you can have some of that skip lesions from that vasculitis. But they definitely were still concerned about a vasculitis. She had issues getting into the bronch. I'm trying to remember. I can't remember exactly why, but I remember that she never actually ended up getting a bronch, which kind of made the diagnosis a little bit more difficult. But the kind of classic shotgun vasculitis workup was ordered. So I wanted to ask you, Ralph, what is kind of your approach to the workup for vasculitis? Because that's kind of one of the more famous $1 million workups that can very quickly add up. And at the same time, a lot of the tests aren't terribly sensitive or specific. So how do you generally approach kind of an undifferentiated vasculitis workup?
Absolutely. One thing, so having done a rheumatology rotation, Dr. Krause helped. So there are two ways she teaches it. Number one is influence your differential on what organs are involved. And that, of course, seems quite obvious for us, but I have to remind myself all the time about that. So that certainly helps. And then number two, what vascular beds are involved? Is it large, medium, or small? And then based on that, you go on to the appropriate workup. I have to apologize here because I'm not a rheumatologist, nor am I a rheumatology fellow. So going more in detail with the vasculitides it will be more difficult.
Not at all what we need, because we're all just learning here. And that's, exactly what you said is exactly what I had written down was, first of all, look at the organ involvement, let that kind of guide you, and then try and figure out, is it small, medium, or large vessels? And kind of just some tips that I found in the literature as far as trying to figure that out. If you're talking like upper extremity issues, claudication, that might be more large vessels. Medium vessels would be like some of your major organs like kidneys, lung, that type of involvement. If you have neuropathy, that's something to ask your patients about, like Rachel was talking about, just saying what's going on, what's new, what's changing. That triggers more of a small vessel vasculitis. And then if we see signs of alveolar hemorrhage, that's classically associated with, ANCA vasculitides, more of kind of a small to medium vessel. And then, just asking about different predisposing factors, new medications, history of lupus, family history of stuff, looking at the skin, seeing if there's any signs of purpura, all of that kind of stuff. So just based on some of the guidelines that I could find, initial labs that we would start with, which is what we did in this patient, was ordering an ANA, a C3 and C4 level, a C ANCA, and a P ANCA. So with this patient, her C ANCA titers ended up coming back elevated at greater than 1 to 1280, and her PR3 antibody was elevated at greater than 0.8. So this was supportive of a diagnosis of ANCA-associated vasculitis, likely granulomatosis with polyangiitis, given her lung involvement and her hematuria that we found on admission. She was eventually transitioned to oral prednisone with a plan to discharge on her taper, and she started on rituximab for granulomatosis with polyangiitis, given her first dose in the hospital. So this was a bit of a surprise, and I was also, it was a very educational case, and I learned that you don't actually have to have a biopsy to officially diagnose GPA. There's the American College of Rheumatology has some different criteria, and if you meet enough of them, then you don't have to have biopsy proven to consider it a diagnosis. And she actually, with her crazy high C ANCA titers, she did meet those criteria. So with her having been on these steroids and starting on rituximab, Rachel, I'll start with you. Anything that comes to mind as far as issues to make sure that are addressed before sending this patient home?
Definitely want to make sure that she has good follow-up with a rheumatologist, because this is something she's going to have to follow up on for the rest of her life. Review all of, now that she's going to be on this prednisone long term, and if not forever, but frequently, she's going to have to be kind of counseled on the long-term side effects of steroids that can happen. And I mean, that's also going to be part of her care with her established rheumatologist as well. For rituximab, I mean, since those target your B cells, going to have to be careful with infections.
Yeah, for sure. So rituximab and steroids. Ralph, what would you send her out on? And then any other kind of social factors or anything that you'd want to check up on?
So there are an incredible amount of long-term side effects of glucocorticoid therapy that you'll need to advise the patient to look out on. Obviously, in this situation, the risk benefit is favoring long-term steroids in her. One thing that has to be sent out on is any patient that has more than 20 milligrams of prednisone anytime during the day for 3 weeks, or 5 milligrams of prednisone just before sleeping for a few weeks, just with the way the circadian rhythm of your HPA axis works, they are considered HPA axis suppressed. And the ramification of this is PJP risk. And so when someone is sent out on long-term steroids, they should have PJP prophylaxis, whether this is TMP SMX, atovaquone, pentamidine, what have you.
Awesome. I love it. And this is one of those things that would be a quick up-to-date search or a quick, guideline search. Just wanted to make sure that she was sent out on vitamin D supplementation and a PPI. Again, those are just prophylactic, being on steroids, and that would kind of be a quick up-to-date search, or even it might even come in the pharmacy order when you're ordering that much prednisone. And then the other things that we found that was actually quite a barrier to her discharge that we had to work through was logistics on the infusion stuff for rituximab. So these various different antibody treatments and stuff that we have for autoimmune diseases are awesome, and they can be completely transformative in our patients' lives, but there's still a lot of logistics that go into it that can be pretty burdensome for the patients. So some of the antibody therapies are injected, and those can be a little bit simpler. The ones that are IV, sometimes you can get home health to be set up to go and do them at their home. Otherwise, you have to set up with an infusion center, and that can be kind of tricky with insurance coverage on which ones they will approve, which ones they won't, and getting all that arranged. And then making sure they have transport and all that kind of stuff. So this is where our social workers, our case managers can be extremely helpful in just helping to navigate that. And that's just something to keep in mind if you think you might be starting medication like this, because that can take a few days to get set up. And those are the types of things that, like in a patient like this, you want to make sure that she's able to get her rituximab. And so you don't want it to be lapsed when she's discharged. So getting financial assistance, getting logistics and stuff set up before a few days before you anticipate discharge can be really helpful for being able to get the patient out when she's ready to go out medically. So that was, just some barriers that we found and overcame with this patient. So we were able to get her set up, able to get her first dose of rituximab in the hospital, which was in and of itself a challenge for the insurance company. But she, last time I checked a few weeks ago in the EMR, she's been doing pretty well on that therapy. So all that being said, awesome discussion. Thank you guys both for your input. Any big takeaway, anything that stuck out to you throughout this case, any learning point or thing that you are kind of taking away from this? Rachel, starting with you.
The eye is really scary because it's not something that comes up a lot, at least not so far in my training. So, I feel like, okay, go forward with your differential, and it's just so broad. It's a lot, and things can get complicated really fast. But if you just focus on what's in front of you, you can eventually get to the diagnosis.
For sure. Well, thanks, takeaways, and then just any final points that you want to give us, clinical pros, anything that comes to mind.
Yeah, one thing. So I looked it up just right now because it came to my mind. Can't believe I haven't thought of this before. So if you give the patient steroids, does that screw up your temporal artery biopsy? And it looks like the answer is no. Off of 2 studies from the British Journal of Ophthalmology. So that's something I didn't know the answer to, so I just looked it up. And then the second thing is, as a med student and also as a resident in my time in the emergency department, I love to get either attendings who are comfortable with it or the ophthalmology consultants to walk me through their panoptic or their direct fundus exam. And so I always would try to seek that. I think that's a skill that shouldn't be lost. It's very easy to say, they'll come and do it, but as internists, that it's hanging in the wall in clinic, it's there for a reason.
Awesome point. Thank you so much for all of your pearls and learning points. It was chock full. I think I'll be going back and watching this through again. Alrighty, well, thank you guys so much. Appreciate y'all being here.
Thank you. Have a good night.
You too.